I already, Carles is already introduced from Barcelona, Spain. Welcome, Carles, again.
Thank you.
We know each other. And he will talk with, his talk will be Gastrocnemius or Soleus?
Whatever you want.
Okay.
No,
yeah, do whatever you like to do. Thank you very much. And for question and answers, I think the best will be that you do that with Slido. Thank you very much. Carles, stage is yours.
Thank you. Thank you very much. So let's just speak a little bit about the Gastrocnemius, but I cannot speak only about the Gastrocnemius without speaking just a little bit about the relevant aspects of the anatomy of the calf, because we divided here between Gastrocnemius and Soleus, but we need to understand the calf, even the Achilles tendon, as a whole complex in terms of anatomy and in terms of functionality. And that, for me, is very, very important. So, first of all, what we show here, what we can see here in that part is the, that's it. No, it doesn't move it. Okay, I show it like that. So what we can see here is that this is the lateral gastroc, this is the medial gastroc, and here we have the aponeurotic component that develops the Achilles tendon, okay? But also, when we look at this more lateral plane, looking from the medial side, we can see that, for example, here in that part, we have a big aponeurotic component, and here is the soleus muscle, and then look especially in that area that I'm pointing here. This was described anatomically by Blitz. Both aponeuroses abruptly fuse and start what we call the Achilles tendon, okay? So that's very important, even that because if we open the medial gastroc and the lateral gastroc and we look in between both of them, we can see the gastroc here, we can see the soleus, and here we can see the plantaris tendon, okay? So that's also really important, the role of the plantaris in that kind of injuries that we will find here. So it's not only about the injuries in the medial gastroc or in the lateral gastroc, it's also about what can we find here and where can we find these injuries. So we need to consider also the plantaris, the trajectory of the plantaris, and all the different places where we can find injuries in the gastroc and the soleus muscle. But if we focus mainly in the medial gastrocnemius, we will need to go exactly to that point here, okay? So this is where 90%, 80% of medial gastrocnemius injuries occur, okay? So, and in this area, what we will find is a very strong myotendinous junction union. And this is quite interesting because a few years ago, I always say that these injuries were like myofascial injuries. And as we spoke before, we need to understand where we are exactly and which is the anatomy and the histological component of every single structure. So this is not a myofascial. So this is a myoaponeurotic junction. Look how strong it is, how dense it is, and how hard it is to pull these muscle fibers from the aponeurosis. But if we look at the myofascial injury, a myofascial tissue or myofascial junction, look how loose it is and how easy it is to rupture that part, okay? That's why we have more problems with myoaponeurotic injury rather than myofascial injury, even though myofascial injury bleeds much more and generate much more hematomas than, for example, myotendinous junction injuries. Okay? So we are located exactly in that point. From here, we need to, as I said, we need to understand that it's all about the anatomy. Okay? So if we understand the anatomy, we understand what's going on with calf injuries. So here we have an ultrasound panoramic view of the whole calf, okay? And what we see mainly is the medial gastroc up here, the soleus muscle, beak and down, and flexoralis longus, even above all of them, the Cacher fat pad, the Achilles tendon, the tibia bone, the calcaneus bone. Look, the different pattern and the different type of fibers that we have between the soleus and the gastrocnemius. That's another important thing that we will need to consider. Okay, but even this sequence and this longitudinal image is very beautiful to look at. The key point when we assess the medial gastroc is the transversal plane. Okay, and we will see why. So, what we look here is medial gastroc, soleus muscle, and both aponeurosis, and what we call the free aponeurosis of the medial gastroc, which is the portion without muscle fibers between the end of the medial gastroc and the Achilles tendon. This is the free aponeurosis, okay? And this, you can put it exactly in that way, and you can see exactly what's going on. But also, if you do a plantar flexion movement, you will see that this moves in terms of a quite synchronous movement between the medial gastroc and the soleus. And this is another important thing that we will need to assess when scanning that area. Okay, so how to manage medial gastrocnemius injuries. So when we go there, we published 2 classification systems about ultrasound classification system and magnetic resonance correlation. So I have to say that if you make me speak about any other muscle injury, I would say that we need MRI to have an accurate diagnosis. But if we speak about the medial gastroc, I think that with ultrasound, it's more than enough to make an initial correct diagnosis and to make a correct follow-up of all the injuries. But we just need to understand 3 or 4 issues that we're going to assess probably here. So this is an infography I made a couple of years ago about the classification system. So what we did is to try to classify. I have to say that I don't like classification systems. Yeah, I did want this classification, but I don't like classification systems because I don't like to be strict with muscle injuries, okay? And there are always combinations between both of them. And is this a 1 or is this a 2A? It doesn't matter. You understand the anatomy, you understand the functionality, you will get the prognosis, okay? So, but anyway, just to start from some point, we started with a type 1, which was a myoaponeurotic injury without rupturing the aponeurosis itself, okay? This is very rare because, as you saw before, it is very hard to disattach that muscle fibers from the aponeurosis. So normally, when you disattach, you also have a tear in the aponeurosis. So this is a very rare one, but we can see sometimes, okay? We can see some waviness in the muscle fibers, but almost everything is quite correct. Clinically, they set very, very fast, they set down. And what we need only is functional treatment, and the return to play, even for professional players, is around 2 or 3 weeks, okay? So what we see is something like that. Just a little bit of thickening in the aponeurosis and a blurred aspect of the fibers attaching that point, okay? Like this one. Now let's go with the type 2. And the type 2 is where there is a little bit of conflictive, because here we need to check the transversal plane, as I said, okay? So when we look at the transversal plane, we need to separate between type 2A and type 2B, according to how big is the rupture in the transversal plane. That means that we can measure quite good how big is the rupture. So if it's less than 50%, we will speak about 2A, and if it's more than 50%, or it's complete rupture, we speak about 2B, okay? We need to understand another important thing is that when we have a rupture in the aponeurosis, there is bleeding in the intermuscular space, okay? Between soleus and gastroc. And then is when we see that kind of hematomas that we all have seen sometimes, okay? But of course, it depends on how big is that hole in the aponeurosis, the more bleeding that we will have, probably. Okay? So, as I said, transversal is the most important thing. And this is in longitudinal. So we can see in both some kind of hematoma in the middle part, okay? And, but as you can see in the longitudinal plane, we don't have that information to say, okay, this is a 2A or this is a 2B. So we need to go to transversal. And also, we need to check with the plantar flexion movement to see if there is a loss in the synchronous movement or not. So, for example, in this 2A, we can see that even the rupture, we can see that the synchronous movement is quite preserved. It's not affected. So they move the same, but with a bit of hematoma in the middle, in between both muscles. But look, for example, to this one, okay? Yeah. Look that the soleus muscle is moving, but the medial gastroc is dead up there. That means that we lost completely the connection between both aponeuroses. Okay? So that we need to recover that connection in order to recover and restore the functionality of the calf muscles. Okay? We will speak later about how we can do that. If we move to type 3, this is a quite interesting one, and it goes along again with the connective tissue and the dense connective tissue ruptures. So we are speaking about that, and you will see that everything looks quite normal, and the injury and the affected region looks very small. But this is a tendinous injury, and we need that they recover slower in terms of metabolism. So we need to be careful with that, okay? And what we see here is just a thickening in the distal part of the medial gastrocmyotendinous junction, but then it moves over to the Achilles part, affecting mainly the the free gastrocnemius aponeurosis, okay? That means this area here, okay? Look here. You can see almost a normal region in that part, but then you can see this rupture in the free gastrocnemius aponeurosis. And normally, as the aponeurosis between both muscles is still connected, the synchronous movement is preserved. So in terms of functionality, they work quite well from the beginning. So you need to imagine something like that. Okay, this is the typical image that we see when we speak about the type 3. And then we go to the type 4. The type 4 is just a rupture of everything. So in summary, it's mainly a type 2B plus a type 3, which is the extension to the free gastrocnemius aponeurosis. And sometimes, if we go even further, we see a type 2B, a type 3, and a partial rupture of the Achilles. And this is not uncommon. So we see that so many times. So for sure, as there is a rupture, we can see huge hematomas, intermuscular hematomas. This is not an hematoma inside the medial gastroc. It's in the virtual space between the medial gastroc and the soleus muscle. And this is in the transversal plane, okay? So, of course, the synchronous movement in that case normally is affected. Okay, not always, because sometimes there is some, it remains there, but mostly, as we can see here, is affected. Okay? And this is the typical image. So what we need, and the first thing we see when we look at the ultrasound scan to the calf is the hematoma. Okay? And the tendency is to say the hematoma is very big, the injury is very severe. And it's not like that. The hematoma, it's just a symptom. It's a manifestation of the injury. So I don't care about the hematoma. Okay? So forget about the hematoma. The important thing here is the structures of the aponeurosis. if they have a rupture or not. The medial gastrocnemius aponeurosis and the free gastrocnemius aponeurosis. And especially then, the dynamic maneuver with the ultrasound scan, which is with the plantar flexion movement of the ankle, to see if the synchronous movement is preserved or not, because this is going to give us the treatment that we need to apply probably. Okay, so we published that, and we have a very, very significant progression in terms of return to play and the grade. Okay, so it's quite easy to see the progression in terms of return to play and degree in the type of the muscle injury. So the big questions here are to drain or not to drain the hematoma. Who says about draining? 1, 2, 3, 4, 5. And the others? Not to drain? 2, 3. We are only 5, 6 people in the room. Okay. For me, it's a matter of a mechanical point of view. So if you have an hematoma like this one in between both muscles and you just leave it there, the body himself is not able to drain all this. So what we will have here is a big fibrotic scar between both muscles in the best of the cases. And what we really need is the thinner scar as we can in order to restore the normal movement between both muscles. So if I have to drain, I drain. And if it appears again the blood, I drain again. And if it appears, I drain again without any kind of problems. Okay, then a little bit of compression for 24, 48 hours and re-scan with ultrasound every week. Okay, and you will release completely this kind of hematoma. So look, for example, the difference between having a scar tissue of this thickness or having a scar tissue of this thickness if we speak that mostly the functional terms of the medial gastroc and the soleus needs to be slicing in a synchronous movement. So obviously we need that. And the second question is to cast or not to cast. So should I immobilize a medial gastrocnemius injuries? Again, this time is a matter of functionality, okay? So we know that we have this normal movement, okay? And we know that sometimes we lose this movement, okay? Look here. Soleus works in isolation. Medial gastroc is only moving because the soleus is making moving, nothing else. Okay? So the thing is, I only cast when I lost completely the synchronous movement between both. So I drain, I cast, and I reevaluate. And when you retire the cast, when I see that there is some recovery in the synchronous movement, then I remove cast and I start loading. Because if I have a big hematoma in between both muscles and I have a loss of synchronicity in that movement, even I do all the physiotherapy I want or I need or more, I won't resolve that problem. So first of all, I need contact between both aponeurosis to restore the functionality. Okay? So I cast and then I retire as soon as I see not a complete recovery, some kind of recovery of that movement. Okay? And also, we need to be careful, as I said, with classification systems because we can have, and we normally have, combined injuries. And that makes it a little bit more heavy or a little bit more complicated to treat because we need to understand that when we have a calf pain and it is not an injury, we have a very, very huge amount of differential diagnosis we should make in order to differentiate calf pain. Okay? And it's not just about injuries or not. So, as a conclusion, for me, ultrasound is the best choice for the diagnosis and for the management of the medial gastrocnemius. The most important thing is to look about the aponeurosis. A rupture free aponeurosis, fibrous affection. We need to think that about a tendinous injury or an aponeurotic injury, so it takes time. Type 2B and 4, more prone to have affection either in the synchronous movement because they lost the connection between both aponeuroses. Classification systems always, not mathematics. Think about this every single time you use a classification system. They are just a starting point. And combined injuries have different prognosis, okay? Just one more thing before leaving in terms of imaging, if you ask. Clinical suspicion of an acute calf injury. Ultrasound scan, no need for MRI. No need for MRI, Rod. Ultrasound scan around 48 hours to see if there is hematoma and bleeding, okay? If there is a medial gastrocnemius or a plantaris muscle injury, we will see that in ultrasound, no doubt, okay? If it's positive, it's because it's a medial gastroc or plantaris. If we have a suspicion of calf injury and the ultrasound is negative, we don't see anything, and that happens quite normal, we need to think about the soleus injury, and then we need to go now, yes, to the MRI scan. Thank you.